each and every one of you all for taking time out of your busy schedules. My name is Brian Sackman. I'm the Territory Manager for the Southern Ohio, part of Kentucky, as well as West Virginia for Pulmonx. And we manufacture the Zephyr valve system. We are extremely excited that you guys have been able to join. Our goal today is to educate you not only on emphysema, but also on Zephyr valves. What is the right patient, the patient selection, the patient workup, the management, the follow-up, the results. What can you expect? We really want you to feel very confident that when you leave this presentation that you can go back and have some really nice conversations with your patients and then be able to refer those patients over with, whether it's patient education materials, over to their respective doctors to have some conversations. So thank you very much. But I also wanted to thank each of you for all that you do. You care for patients that are a very sick patient with emphysema, and there's a lot of moving parts with these patients, and we just truly appreciate you. We appreciate all the time that you put into these patients. So thank you very, very much. Two people I want to thank personally, or three people, for putting together this program. So this is the second program we've done here at Pulmonx. And late last year, Dr. Younger, as well as his respiratory therapy manager, Gretchen Koloff, we sat down and we were discussing some educational opportunities for the practice, for their practice, the Dayton Respiratory Center. And Gretchen suggested to put together a program for respiratory therapists, because we know that you guys are such an important, integral part of the management of these patients. And there's a lot of moving parts, obviously, and there's a lot of touch points, a lot of people that have touch points with these patients. But the respiratory therapists are very, very, very important to this process. So working internally with my marketing manager, Travis Anderson, we have formed a partnership with the Dayton Respiratory Center. Many of the doctors there are using Zephyr. But at the end of the day, we were able to work with ARC and get this accomplished. So thank you all very, very much. I'm going to go over a few housekeeping items. First off, most importantly, as I said before, we want you guys to walk away with a lot of confidence. So there's no question that is a wrong question. We want you to leave and have every question answered. So there's a function at the bottom. If you move your cursor, a little icon that says Q&A. If you could just click on that and ask any question that you want, we as the panelists, as well as Dr. Younger, will be able to see these questions, and we will get to these after the presentation. But again, we want you to ask every question. There is no stupid question. Secondly, at the end of the program, you'll be required to complete a survey. Once you do that, that will go to our marketing team. We will then send that over to ARC, and Travis Anderson, our marketing director, will get back to you with your AARC CEU certificate. So we'll take care of that. But without further ado, I want to introduce Gretchen and Dr. Younger. They are with the Dayton Respiratory Center. They truly are a center of excellence. They are the largest user of Zephyr in the state of Ohio. They've done the most cases. They've got 5 doctors now that are trained with Zephyr. They're having outstanding results. But truly, it takes a team to put this program together. They have multiple coordinators, but the lead coordinator is Gretchen Koloff, who you can see on the screen. Just a fantabulous person. She's a respiratory therapist, and she helps run their program. So it truly takes a team effort. So thank you to you both. The good things about Dr. Younger, he's done his background and teaching at Ohio State, joined the Dayton Respiratory Center, and they have a flourishing practice down there. They're growing, and of course he himself has done 25 plus Zephyr valve cases, so he's got a lot of different experiences with different patients. They've opened up 2 facilities, 2 hospitals, with a 3rd hospital that's soon to be open. So without further ado, I'm going to turn it over to both Dr. Younger as well as Gretchen to walk through the presentation. And again, we thank you for attending the program. Okay.
Thanks, Brian. Really appreciate that. Afternoon, everybody. I'm going to try to get through these slides in about 25, 30 minutes and leave plenty of time for everyone to ask questions. That is a picture of Atrium, and it's one of our centers of excellence for valves. We've actually been doing cases down at Atrium for the last 5 or 6 months now, and we've had quite a bit of success. Just a couple questions just to get you thinking about the kind of patient that we're going to look at for valves. First question here, and obviously you may not have the answers to these right now, but hopefully by the end of this presentation, you guys have a good idea who we're thinking about. So what's the ideal forced expiratory volume range for a COPD patient to undergo intobronchial valve intervention? Is it that person with an FEV1 of 70 to 100% predicted, so somebody with mild to moderate disease? Is it somebody with just moderate disease, an FEV1 of 50 to 70%? Somebody with severe to very severe disease, FEV1 of 15 to 45%? Or are we looking at those folks with very severe disease, less than 15% of predicted? So just something to keep in mind. The second question, what surgical procedure are endobronchial valves intended to replace? Lung transplant, lobectomy, tracheostomy, lung volume reduction surgery. I think all of you out there are very familiar with emphysema, but we'll just touch on this for a few seconds just to talk about the scope of the problem. COPD, now the 4th leading cause of death in the US and around the world, stands behind coronary artery disease or heart disease, cancer, accidents, and then you've got COPD. But in our country alone, it's thought that there's about 27 million people with COPD. 15 million of those have been diagnosed, and we still have about 12 million that are undiagnosed out there. So quite a population of patients to deal with, and these are patients that are looking for whatever we can give them to help them feel a little bit better. Under that umbrella of COPD, you have emphysema and chronic bronchitis. I won't belabor this bottom portion of the slide too much. You guys know how this works. That healthy alveolus is down in the left-hand corner, but those smokers, those walls of that alveolus break down, and you end up with less surface area of the alveolus, and they don't exchange air as well. They develop air trapping, they develop hyperinflation, and it becomes much more difficult for them to breathe. When you look at our state, the state of Ohio, about 745,000 patients in this state with COPD. When you look at our population, we probably think it's more than that because we deal with this so much more often, but it is probably about 7 to 8% of our population that actually suffers from COPD and that we can help address this problem. This next slide just talks about COPD and tobacco risk. Interestingly, you guys know 90% of patients that have COPD are smokers, or they've developed that COPD from smoking. But another interesting point is not everybody that smokes goes on to develop COPD, and that point down at the bottom, only 15% of smokers develop COPD. And it's always interesting that for me in the office, somebody comes into the office, they've got a 100-pack-year smoking history, and I think they're here for COPD, and they're actually here for something else, a lung lesion, or they're here for sleep or something else, but yet they have no issues with their breathing at all. So not everybody goes on to develop COPD that smokes, but most of COPD is related to tobacco. You do have that 1% that's related to alpha-1 antitrypsin, and I think most of you are aware, but alpha-1 antitrypsin is a protein that helps protect the lungs from any environmental agent, including tobacco use. Those folks that have a deficiency, if they don't smoke, they typically don't go on to develop symptomatic COPD. They can still develop COPD, but it's typically not symptomatic. It's the smokers that have alpha-1 antitrypsin that go on to develop symptomatic disease. And then you've got about 9% that suffer from environmental induced COPD. And I tell you, it's been very interesting in Middletown. We've been down in Middletown for about 3 or 4 years. And just the number of patients that present with COPD and lung cancer that have never smoked. So it just goes you to show that there are definitely environmental issues, pollution issues that go on to develop COPD as well as lung cancer. But we have a lot of industry down in Middletown. So though some of those people haven't smoked, they do still go on to develop COPD. Another issue down in Middletown is wood-burning stoves. And I've got several patients with wood-burning stoves. And again, some of them haven't smoked, but yet they've gone to develop severe COPD, and it's related to that wood-burning stove in the house. Over on the left-hand side, just a really elegant study that was actually done about 30 or 40 years ago now, looking at tobacco use when patients quit smoking And I think the slide just goes to show that every time we see these patients in the office, we ought to be encouraging them to quit smoking. And it just shows you that no age is too late to quit smoking. That top line looks at non-smokers. So somebody like me, somebody like you that has never smoked, and what happens with lung function. Typically about the age of 35, we all start to lose a little lung function, and that's what you see in that slide. But though we're losing lung function, we never go on to develop COPD or emphysema. As you move on, the line, the darker line at the bottom, those are folks that smoke and never quit. And you can see as time goes on, they're rapidly losing lung function. So as a non-smoker, I'm losing about 10 to 15 cc's of air each year. As a smoker, they're losing upwards of 60 cc's each year. So if they continue to smoke, they continue to drop on that curve in terms of FEV1 over time. And you can see right around the time they hit that 30% range, when they move into the very severe range, they've developed significant disability. But if you can get them to smoke at any time, they're going to come back to parallel with that curve of a non-smoker. So you can see if you get them to stop smoking at the age of 45, they retain quite a bit of lung function. We can't give them back what they've lost, but they do retain function and they come back to parallel, almost parallel with that line of a non-smoker. But even the patient that's down there at the age of 65, they still are able to retain some function and actually live longer because they've actually stopped smoking. This is just looking at healthy lung tissue on the left, and then what happens, those smokers, again, I told you those walls of the alveoli break down. They develop hyperinflation, they develop air trapping. Many of them can develop pulmonary hypertension because those vessels are strained that are sitting in the lungs, and they develop pulmonary hypertension as well related to their emphysema and COPD. Just another picture of actually how does smoke affect the lung, and those noxious fumes oftentimes are moving into those upper lobes. And I don't have a pointer here, but you can see the upper lobes are very emphysematous, have bulla there. The lower lobes look a little healthier. And we know that this doesn't happen with every case. Some cases are pretty homogeneous in terms of emphysema and where it is, and it will affect all 5 lobes equally. And then you have other heterogeneous cases like this, where the upper lobes are predominantly affected and the lower lobes are more spared. But typically, a lot of times you'll see that upper lobe disease is worse, but every patient is a little different. As disease progresses, patients develop more trouble. And I always tell patients the worst thing you can do is either sit down on the couch or sit in the recliner and not get back up, because then it's a slippery slope, a very quick, slippery slope towards death. So as that disease worsens, they develop hyperinflation, they develop shortness of breath. Well, when that's happening, that activity level starts to fall off. And this is where it's important to tell them, you got to remain active. If they don't remain active, that decrease in activity leads to a reduced exercise capacity and increased breathlessness. And unfortunately, it's a downhill spiral from there. So as they develop more shortness of breath, they develop a worsening of their activity level, and then they become further deconditioned. And then as that's happened, that mortality risk goes up significantly. So what are our treatment options? And I like to joke that 20 years ago, actually it's probably a little longer now, 25 years ago, it was very easy to be a pulmonologist. And pretty much anybody could have been a pulmonologist because the only things we had available to us were Convivent and albuterol. So it didn't matter if we were treating COPD, asthma, lung cancer, sarcoid, everybody got put on Convivent, everybody got put on albuterol. Well, now we have many more medications available to us. It's a little more difficult to be a pulmonologist now. And when you open our drug cabinet, it's just a rainbow of colors of different inhalers that people can use. And those inhalers might be for asthma, might be for COPD, sometimes for both. But we have different pills and different inhalers that we can now use to maximize their therapy. Once we move beyond that medical management, as they're moving into more moderate or severe disease, or they're becoming more symptomatic, then I start to consider pulmonary rehabilitation and trying to get them to join pulmonary rehab. A terrific program, not only for them to get exercise, but it teaches them what they can do at home on their own. So that nice 8 weeks in rehab, and sometimes they can go further beyond that and join a second program, but that 8 weeks in the program allows them to be comfortable with what they're doing. They spend a couple hours a day with a respiratory therapist twice a week. and they feel comfortable in that monitored environment. And then when they go home, they can continue to do these exercises. And it's really important to keep them up. But they also get help in how to breathe better, how to get themselves out of trouble when they're in trouble. In pulmonary rehab, we talk about diet. They also get to talk to their peers. So they get to talk to other patients that have COPD or emphysema. And you know what? They might get to say, hey, you know what? Dr. Bong's doing this for my COPD. Maybe you should ask Dr. Younger if he could do this as well. Or Dr. Goyle's doing this for my COPD. Why don't you ask your doctor if somebody else can do something for you? So they get different ideas and they talk amongst themselves. And I think it's great because it also gets them out of the house and a little more social interaction. And then in the past, we'd move right on to lung volume reduction surgery if they had the proper lungs for that. And previously, you know, back in the 1990s, early 2000s, before the NET trial came out, when patients had emphysema, if you could find something to cut out, the surgeon would go when and cut it out. It wasn't necessarily just the upper lobe. But what NET showed us was that the patients that benefited most from surgery were the ones that had upper lobe disease. So they had to have predominantly upper lobe disease. The lower lobes had to be spared, but they also had to benefit from pulmonary rehab. Well, you can guess that's going to be a fairly small subset of the emphysema population. It's not a large portion that has predominantly upper lobe disease and also benefits from pulmonary rehab. But the NET trial showed us those were really the only patients that benefited. And then once they become severe enough, looking at the possibility of lung transplant. Unfortunately, with lung transplant, mortality is still pretty high. It's definitely improved in the 25 years I've been practicing. Mortality now, at 1 year is about 80% for single lung transplant. But when you move on to 5 years, we're at 50%. So you really have to gauge correctly which patient should be going for transplant, because some of these folks will, whether they go to surgery or not, may actually live that 5 years. So it's really trying to find the right time to actually send them for transplant. Well, and then in the U.S., the valves have now come along. And where do those valves fit in? Right there in between pulmonary rehab and lung volume reduction surgery. And this is a non-invasive way of actually creating that lung volume reduction surgery. You can see what a valve looks like there. Very small, smaller than the size of a dime. And it's performed in the bronch suite. So what we tell these patients going in is they expect to be in the hospital for about 5 days, 4 to 5 days. We actually do the procedure in the bronchoscopy suite under general anesthetic. And we'll talk about the procedure a little bit more, but we'll do the Chartis system and take a good look at the airway and make sure their fissures are intact. And then once we ensure that fissure is intact, then we're going to place anywhere from, 3 to 6, sometimes 7 valves. But generally, it's going to be about 3 to 4 valves that we're going to place. I'm going to show you a little video here. That's the valve again. And let me show you the video, and I'll try to speak through this. I don't think you can hear the volume. So. This is the valve. We'll face it. Here in a second, you'll see us going down into a patient's lungs. So the bronchoscope there is going into the trachea. Now we're moving into the right upper lobe. And we're going to place this valve in the anterior segment of the right upper lobe. You're about to see that happen. We'll go up to the stick that has the valve in it. Release that valve. Bring the subsegment of that anterior segment. And what the valve does is allow the air to exhale or come out of that segment, but it doesn't allow any air to go back into the segment. With the segment that's going to close down or become atelectatic. When that becomes atelectatic, now that lower lobe to actually expand into that space, but also free from the diaphragm. So when you have all that air traffic hyperinflation, the diaphragm's flattened, that muscle's not working for you. And once that muscle starts working for you again, we actually see improvement in lung function. But also with that air-trapped lung being closed down, it allows that healthier lung to move into that space, and now you're using that lung. And I think you can, hold on, you can go back a slide. So if you can see here, this is the valve opening and closing down in the right-hand corner. So when that valve opens, air is exhaling from the segment, and this is a perfectly functioning valve, and then it closes when the patient inhales again. And eventually, once all the air exits that segment, the valve will close and remain closed. So you won't see it keep opening and closing like this, but eventually it does completely close. Moving on, what benefits do patients receive from these valves? There have been several studies that looked at this. This is some of the data from the Liberate trial from Preiner's study. And patients experienced reduced breathlessness. They had a greater ability to do activities. So their activities of daily living improved. It was easier for them to get dressed, easier for them to get washed up, easier for them to do household chores, and also, go for walks and actually get out of the house more. I can tell you an important thing for me, a lot of my patients just want to get to their grandkids' games. Now, in this time of COVID, that's a little different, but in the past, it was that just ability to go enjoy some of their grandkids' sports activities. And many of my patients can do that now. But they have fewer limitations in their ability to do activities, or some of them even return to work. They feel more energetic, and really more importantly, they have confidence in leaving their house now. They don't feel like they're going to get so short of breath that they can't leave the house or they're going to get stuck somewhere. And I can tell you, I had a gentleman, I put valves in about 8 months ago. This man had not left his house for 5 years except to come see me in the office every 3 to 6 months. And after we placed valves, he's out actually now going up to Troy and Tip City every weekend to go visit horse farms up there. And he had not done that in 5 years, but now he has the confidence to actually do that because he feels so much better. What's the optimal candidate for Zephyr valves? Typically, they're going to have an age greater than 55 years. They are going to be short of breath with exertion, and that's despite advanced inhaler regimen. So we're already going to have them possibly on a Trelegy or a combination of Symbicort and Incruz, Symbicort, and so one of the combination agents, and they'll be using albuterol. Some of these patients may already be on Daliresp, but we're going to have them maximally managed on inhalers before we would take this approach. They have to quit smoking, and this is trouble for some of them, but typically they come in pretty excited, and those patients that want to get this done, they are willing to quit smoking, and they really need to be tobacco-free for 4 months. Oftentimes they've gone through a pulmonary rehab program for 4 to 6 weeks. Many of my patients have already been through pulmonary rehab, and then actually after the valves go in, I try to enroll them in pulmonary rehab again. And typically, after they've gone through and been through rehab for over a year, they will typically gain benefit again from going through the program again. So how do we go about evaluating these patients? Clinical screening. First, we get a pulmonary function test, and we'll do a walk test. And I'll show you what those PFTs have to look like and what that walk test looks like in a second. They also have to be medically stable. So we don't want any disqualifying comorbidities. If they have coronary disease or active angina, that's not a patient I'm going to put a valve in. If they have a significant cardiomyopathy and that EF's less than 45%, that's again not a patient I'm going to put a valve in. So typically we're looking for folks that are more stable. They can have comorbidities. They can have a history of coronary artery disease that's well treated. They just can't have angina at the time. They can have a history of cardiomyopathy just as long as that EF's above 45%. So many of these patients are pretty sick, and we can still do the procedure. You just want to make sure that you can safely get them through the anesthetic portion and get them through the procedure and watch them in the hospital after that. If they meet criteria for the PFTs and the walk test, they are medically stable, then we move on to a specialized CT. So it's called a static CT, and that CT is going to evaluate not only the fissures for me, but also where are we in terms of their emphysema. Can I find one lobe that really stands out as a lobe that's good to actually place these valves in? This specialized CT or static CT, it's essentially a high-resolution chest CT with very fine cuts. So cuts that are anywhere from 0.5 millimeter to 1.5 millimeter, so we really get a good idea what those lungs look like and see where the emphysema is. This is what the report looks like, and I'll show you this blown up a little bit more in a second, but it gives me a good idea, again, which lobe is the sickest. And it doesn't just have to be the lower lobe. I think in these two pictures I showed you, or the upper lobe, these two pictures I show you, it shows you upper lobe disease. Interestingly, Brian told you we've done about 25 cases, And most of those cases have actually been lower lobe disease that we've actually gone after and helped that patient feel better. A handful of mine have actually been upper lobe disease. Once we've determined with the Stratix that they're a good candidate, and we've done some other testing, then we move on to the procedure itself. The first part of the procedure is to make sure that the fissure itself is intact. So we'll go over this a couple of different times, but what we want is a collateral ventilation negative fissure. So you don't want air crossing from one lobe into another. And so those of you that know much about coronary artery disease, folks that have built up that coronary artery disease over time will typically build up collateral vessels. So they'll feed the heart from newer vessels that they've developed because they've had time to do that. Well, in a sense, this is something similar. So that fissure is there. Now, patients don't develop new fissures, but that fissure, if you've got ventilation that's going across one lobe into the other, putting valves in aren't going to do me any good or do the patient any good. So if you can tell in this Stratix report here, the upper lobe, that would be that right upper lobe. That would be what I'm going after, that really black one. That's the right upper lobe. But what I want to make sure is that there's no air coming across the fissure from the right lower lobe into the right upper lobe. And that's what the Chartis system allows me to do. And the Chartis catheter is a catheter that a couple of centimeters up has a balloon on it. And I put the balloon in the segment I'm concerned about, and I make sure that over the next 2 to 15 minutes, air eventually stops coming back at me so that I know there's no collateral ventilation there. And if there is no collateral ventilation, then we can move on to placing valves. And typically we do that all in the same procedure. So looking more specifically at how you qualify, these are the PFT criteria that qualify the patient. So we want to see a post-bronchodilator FEV1 between 15 and 45%. So somebody that has severe to very severe disease. We want to see hyperinflation and air trapping. So we want to see a total lung capacity greater than 100% of predicted. We want to see a residual volume greater than 175% of predicted. And then we want that diffusion capacity to be greater than 20% of predicted too. So I don't want to take out a lobe when they've got less than a diffusion capacity less than 20%, because then they're going to have a little more trouble. If they're already less than 20%, or right around that 20% mark, they're probably on some oxygen, and I don't want to have to go higher in that oxygen requirement. They need a 6-minute walk distance between 150 and 500 meters. If it's less than 150, they're probably not going to see too much benefit from valves. If they're over 500 meters, well, they're too healthy for valves at this point. And they're not ready for valves at this point. Down the road they may be, but we want to see that 6-minute walk distance less than 500. And then in terms of arterial blood gas, we need to make sure their PCO2 isn't greater than 50. We want to make sure they're not too hypercarbic, but we want to also make sure that on room air, their PO2 is no lower than 45. So PO2 greater than 45 on room air, and a PCO2 less than 50. So this is a blown up picture of that Stratix report, and essentially black is bad, or black at least is a lobe we're going to go after. And this is somebody that does have heterogeneous disease. So that right upper lobe is the sickest lobe here. And I'm looking at that voxel density, so you can see the second row down at the bottom of the screen there. So we want to see a voxel density that's greater than 50. And in this case, the right upper lobe is a 74, so this would be a good lobe to target. Now, you can also look at the fissures there. So you have 2 fissures on the right, and you can see a dark black line, and you can see a dotted line. The dotted line suggests to me that there's probably some collateral ventilation over that fissure between the right upper lobe and right middle lobe. But when you look at the main fissure, that looks, it's 100%. So that suggests to me that this should be CV negative or collateral ventilation negative. So I would actually look at putting valves in the right upper lobe and the right middle lobe here. If I only put valves in the right upper lobe, there's a chance that air from that right middle lobe is going to move into the right upper lobe, and the right upper lobe will never close down. So in this case, if I know that main fissure is intact and CV negative, then I can actually put valves, probably 3 valves in the right upper lobe and 1 valve in the right middle lobe, and I'll take out that combination of right upper lobe and right middle lobe. And you can see that has an inspiratory volume down at the bottom in combination of 2,228 cc's. I'm taking out a significant amount of air-trapped lung there, and I'm allowing that right lower lobe that's healthier to move into that space of the right upper lobe. They're able to use that right lower lobe better, and now that diaphragm should be more curved and they should be able to use that muscle better. So in this case, that's what I target. Now, let's just say, for instance, I do the Chartis procedure. So I'm putting the balloon catheter. In this case, I would actually put in the right lower lobe to make sure the right upper lobe and right middle lobe, make sure that that main fissure was intact. But say I put it in there and I continue to receive air back. I leave it in there for about 10 minutes and I never see what I want to see, and the air continues to come back at me. And it suggests that even though it says 100% on the Stratix report, suggests to me, well, you know what, we don't have a CV negative fissure here, it's CV positive. Well, in this case, I can still look at the other side. I can look at the left upper lobe as a secondary target, and then I would move to that side and put the Chartis catheter in that left upper lobe and see if that fissure on the left side is actually CV negative. And if it is, I can actually put valves in the left upper lobe. So though it's not as sick as the right upper lobe, if the fissure's intact on the left side, I still should get a pretty good benefit for this patient by taking out the left upper lobe or causing that lobe to become atelectatic. And this is just a better slide looking at CV negative and CV positive. Again, now on this one, it's the left lung we're looking at, and you've only got one fissure on that left side, but I'm going to put that Chartis catheter in there, and if I'm targeting the left upper lobe, I want to make sure that after anywhere from 2 to 15 minutes, air stops coming back at me with that balloon blown up in the left upper lobe. And if it does, I've got a CV negative fissure, and this patient's a good candidate for valves. But if, on the other hand, we see what we do on the right-hand side, if air continues to come back at me, then I know I've got a CV positive fissure, and this patient's not going to benefit from valves. So if I put valves in this patient in the right upper lobe, unfortunately, it's never going to become atelectatic. We're never going to get the benefit we're looking for because air is going to continue to move into the right upper lobe from the right lower lobe. So in this case, this patient, unfortunately, would go home without valves, unless we could look at the other side. So we'll look at some of the data now. I think we've probably got about 10 more minutes here. We'll look at this data. There have been about 6 studies looking at valves. If you look at this timeline, the NET trial was right there around 2010. And again, remember in the NET trial, we found that the surgical patient that would benefit was those patients that had upper lobe disease only, but also benefited from pulmonary rehabilitation. So again, a small subsegment of the population. With this non-invasive approach, we found that we can go after any lobe, not just an upper lobe disease. We can go after any lobe and create some improvement for the patient. The studies that have been done in the U.S. are the Stelvio Impact, Liberate, and Transform trials, and those were trials anywhere from 2015 to 2018. I'll show you a little bit more about these trials. In terms of outcomes, these trials had anywhere from 68 to 190 patients involved, and they were trials that went for 6 months to 12 months. And Liberate trial is the only trial that's gone 12 months, looking at heterogeneous disease. Some of these trials looked at patients with homogeneous and heterogeneous disease. So what I mean by that is the homogeneous disease is that patient that has emphysema essentially equally throughout all 5 lobes. The heterogeneous patient is that patient where we can identify 1 or 2 lobes that would be good targets for valves. In all 4 of these studies, significant improvements were found in lung function, in exercise capacity, looking at that 6-minute walk distance, and in quality of life scores. And that's the SGRQ. We use that in study quite a bit in the trials that we use. And you have to see an improvement of at least 4 points to be significant. And in all 4 trials, they did see that in that quality of life data. We're going to look a little more closely at the Liberate trial. This was Dr. Kreiner was the lead investigator on this trial. It was a U.S. approved trial in collaboration with the FDA. It was the 4th randomized clinical trial using Zephyr valves in CV negative patients. So again, folks that fissure was intact. And it was the first with a 12-month follow-up in both treatment and control arms. Multi-center international randomized controlled study. 190 severe heterogeneous emphysema subjects randomized 2-to-1 Zephyr valve to standard of care, 24 sites, 4 countries. some of the secondary outcomes here on that first portion on the left-hand side, looking at FEV1. These patients saw a greater than 100 cc improvement in their FEV1 in those valve patients compared to control subjects. Most of you probably out there know, we as pulmonologists look at 100 cc's as being that critical cutoff, especially when we're looking at inhaler use. When they're using inhalers, do we see at least that 100 cc improvement? And in this case, with the valves, we did see a 100 cc improvement, a little more than a 100 cc improvement. In the middle there is the 6-minute walk distance, the change in baseline, and you see here a significant value as well, a significant improvement in that 6-minute walk distance in the valve patients versus the control patients. And unfortunately, you see the control patients continue to worsen over that 12-month period. And then finally, the SGRQ data. And there you want to see a negative value, you want to see an improvement. And there we saw a little more than a 7-point improvement in the valve patients versus less than a 1-point improvement in those control patients. So again, in all three, FEV1 or PFT data, 6-minute walk distance, and quality data, we're seeing significant improvements across the board. So valves have been performed around the world, and especially in Europe, for more than 15 years now. So though these were just approved in the US at the beginning of 2019, over 15,000 cases have been done globally, many of those in Europe. So this isn't a new procedure, it's just new to the US. And you can see down at the bottom there, I won't go through every one of these, but Zephyr valves now are included as treatment for severe emphysema in many global and national documents. And I'll give you a chance just to look through all those. I'm not reading through them all. So I told you about the good. Well, there are some risks. We'll talk about that as well. So not every patient benefits. And this slide kind of points that out. If you look at there on the left-hand side, this is the FEV1 responders. So when you look at all subjects in both the control and the valve, especially when we look at the valves, a little less than 50% of patients saw an improvement in their FEV1 compared to controls and also to one another. So you can see no change in a little less than 40% and a little less than 20% actually worsen. I will tell you the good thing here about valves. So if I do surgical procedure on the patient, so if we do lung volume reduction surgery, obviously there's no going back. So once I've taken that lung tissue out, if they don't see improvement or if they get worse, there's not much I can do. I can't go back and give them that tissue. The nice thing about valves in this non-invasive approach is if the patient happens to feel worse, or they say, you know, I don't feel any different, can you get these valves out? I can. I can go back and take the valves out, and we get them back to where they were before. But you can see there is a significant improvement. We're seeing just, again, a little less than 50% will be those FEV1 responders. When it comes to SGRQ data, a little less than 60% see an improvement, less than 20% no change, and about 25% actually felt worse. And then finally, with the 6-minute walk responders, a little more than 40% responded. So you're seeing an improvement of 40 to almost 60%, whether you're looking at FEV1, SGRQ, or 6-minute walk distance. But not everybody, again, will respond. This is looking at some of those outcomes in terms of poor outcomes. So there were some deaths early on in Liberate. So there was a 3% risk for death. Those were patients early on in the study that they were sending home right away. And what they found was they needed to keep patients in the hospital for a few days. And that's why we now keep patients in that 4 to 5 days. It's to make sure that if they do develop a pneumothorax or a tension pneumothorax, we're there to take care of it. When they were going home, you develop a tension pneumothorax at home, oftentimes you don't have a chance to get back in. So those were those 3% of deaths. In terms of pneumothoraces, 26% of patients, 27% of patients will develop a pneumothorax. Most of those occur in the first few days, about 80%, but you can see that 27% of patients will suffer a pneumothorax in the first 45 days, as compared to the control where there was 0. But even further out, 46 days to 12 months, there's still about a 6.5% chance of a pneumothorax. Then we move down to COPD exacerbation. In that first 45 days, a little less than 8% of patients suffered an exacerbation if you were in the valve treatment arm. But in those that were in the control arm, it was about 5%. When you look further out, there's trending towards those folks that are controls doing a little bit worse. So COPD exacerbation in the valve arm, 23% versus 30 to 31% in the folks that were in the control. Pneumonia, in those first 45 days, less than 1% of valve patients will develop a pneumonia. None did in the control arm in the trial. But when you look further out, it was 5.7% in the valve arm, but 8% in the control arm. And then lastly, respiratory failure. When we first put those valves in, about 1.6% of patients did develop respiratory failure. Control arm 0. But when you look further out, less than 1% suffered from respiratory failure if you're in the valve arm, but 3% in the control arm. So when you look at that COPD, pneumonia, and respiratory failure, the further out you went, the trend seemed to be improved towards the valve arm. So this is a picture of what is a tension pneumothorax. This is what we need those patients in the hospital the first 4 or 5 days for, to make sure that if this does occur, we're there to take care of it. For a pneumothorax that's not a tension, typically you wouldn't see the heart border pressed over so much to the left-hand side. And that trachea, which is right now midline or actually shifted to over towards the contralateral lung a little bit, you'd actually, for just atelectatic lung, it'd be actually pushed the other direction, towards the lung that's involved. But in this case, the trachea is pushed the opposite way. The heart border is pushed the other way. This is a tension pneumothorax, and we've got to address this quickly or this patient could actually die. So we're always prepared in the hospital. We've got a needle decompression kit in the bronchoscopy suite that stays with the patient in the PACU and goes with them to the room. And then we have pneumothorax trays sitting right there at the room for them. If they develop a tension, we can either put a needle in right away if we think it's a tension pneumothorax, or if we think it's a pneumothorax they can tolerate, we can either get them down to special procedures and get a chest tube placed in. One of the pulmonologists can, one of the CT surgeons can, but there's somebody available that can actually put that chest tube in. One more slide about pneumothoraces. Again, I told you earlier, about 27% of patients with valves can experience a pneumothorax. This slide shows you that most of those pneumothoraces, about 80%, are going to occur in the first 4 to 5 days. And what's important there's a couple of important points here. One is, whether the patient experiences a pneumothorax or not, their outcomes are typically the same. They have comparable benefits. So even if patients experience a pneumothorax, they can still have a good outcome. We take care of the pneumothorax and they can still see improvement in their lung function. There are, in terms of those pneumothoraces, some of them we can just watch, we observe, and we don't have to put a chest tube in. I can tell you our site was very lucky. We were beating the odds for that first year, and I had not had a pneumothorax in the first 23 cases. And 2 weeks ago, I had pneumothoraces on a case on Monday and a case on Tuesday. So the odds you knew they were going to catch up with me at some point, and they did last week. The first lady, she was tolerating it well. We went ahead and put a chest tube in. Again, it was the first pneumothorax we had seen, so we did put a chest tube in, but I think we probably could have got away without a chest tube. We probably could have just observed her. The pneumothorax we experienced on Tuesday, I was able to watch. It was a small apical pneumothorax. We were able to watch it improve over the next 3 days, and she didn't require a chest tube. So a small amount of them you can't get by with observation alone. About half of them will require a chest tube. They will improve with the chest tube, and you don't need to do anything else. And once that pneumothorax resolves, you can pull the chest tube out. A small percentage of patients did require a valve to be pulled out. So if they continue to experience a pneumothorax or an air leak, after about a week, we'll go in there and pull out the proximal chest tube, or not the chest tube, the proximal valve. So we'll pull out one valve. And we'll give them a couple days to see if that pneumothorax resolves or if that air leak resolves. And if it does, we stop there. But then about 6 weeks later, we can come back and we can try to put that valve that we pulled out back in. A small percentage of patients, you pull that proximal valve out, and unfortunately, they still continue to have an air leak or a pneumothorax. And in that case, you actually have to go in and remove all the valves. But that's a small percentage of patients. So wrapping this up, down at Atrium, we do consider ourselves a center of excellence for valves. We have a multidisciplinary program for COPD. We will track people throughout, take care of them early on, try to get them into pulmonary rehab, but we can offer lung volume reduction surgery with our surgeons if necessary. We can do this non-invasive approach with valves for the appropriate candidate. We have everything involved that we need to, so we can do all the screening at Atrium, from their PFTs, their blood gases, their echoes, their CAT scans, and if we need a SPECT CT, a CT that gives me a good idea where perfusion is. So what I mean by that is, we didn't talk about that earlier, but some patients, I've got a lobe on each side that I think would be a great candidate, and I can't decide which is the best lobe to do. And I'll have them get a SPECT CT, which tells me perfusion to both of those lobes. And in that case, I know whichever lobe is getting less perfusion, I know that's the lobe I want to go after. And we can offer that as well. But we also have processes in place to track and improve care quality. We are focused on advanced COPD down there. And then we also do quite a bit of research with COPD. So we have, not necessarily down at Atrium, but our practice, we do quite a bit of research in COPD and asthma, so we do that as well. Now, obviously, these patients come to us pretty excited. We've been very fortunate. We've had patients come from Indiana. We've had patients come from 2 or 3 hours south into Kentucky. We've had patients come from the east side of Ohio. So we've had patients come from all over. They're very excited when they get to you, and they tell you they want these valves, and they want these valves as quickly as you can put them in. But you have to talk to them and let them know, we just need to make sure you're the right candidate. We really want to do this for you, but we don't want to harm you. We want to make sure you benefit from these, and we want to make sure you're the proper candidate. Unfortunately, not everybody's a good candidate for valves. And the moment you tell them they're not a candidate for valves, obviously they become very deflated. And there's other options for them. And some of those patients come to me and they're only on inhalers, or they're not on max therapy. And oftentimes we'll even maximize that therapy for them before we start talking about those valves. But once I've had to tell them they're not a candidate for valves, I want to look at other solutions for them. And those folks that might have chronic bronchitis or create a lot of mucus that's difficult to cough up, we may put them on N-acetylcysteine and see if we can make it easier for them to expectorate, or give them a flutter valve, or maybe even a chest vest to see if they can expectorate easier. Those patients with a chronic bronchitis will look at Zithromax. And typically when the first studies came out, we were doing this on a daily basis, but some of these patients can develop hearing loss. So I can tell you anecdotally in my practice, I've backed off to every other day or 3 days a week, a low dose, and it still seems to provide the same benefit to them. Another option is Daliresp. Again, Daliresp helps cut down on exacerbations, also helps cut down on their cough, so those chronic bronchitis that you've already got maxed on all the inhalers, Daliresp is an option. Typically, I'll start off with 250 micrograms, and if they tolerate that dose over the first month, then I'll bump it up to the 500. The thing about Daliresp is diarrhea. The studies that were done would suggest about 17% of patients experience diarrhea, but I think it's higher than that, at least anecdotally, and I'll see upwards of 50%. And sometimes that diarrhea is pretty profuse, and many of these patients, they just cannot tolerate diarrhea or loss of volume. So I just let them know up front, if you develop diarrhea on the smaller dose of the Daliresp, you just discontinue. Then we move into non-invasive ventilation. The Life 2000, you can see that gentleman in the picture. He's got a Life 2000 portable vent there. When the Trilogies, for those of you that are familiar with the Trilogy or the non-invasive ventilators first came out, the Trilogy was actually meant to be a portable unit, but I think most of you know it's too heavy. It weighs almost 20 pounds. And for a COPD patient to try to carry that around, it's not too feasible. So the Life 2000 came out a couple years ago, and it's a nice alternative for those folks that need a little bit more. They need that extra flow, and that Life 2000 can provide that to them and give them that in a BiPAP form of way, and a portable unit that allows them to get around better. And then for those folks that we see frequently in the hospital are frequent exacerbators, those folks with really severe disease that aren't sleeping as well, or we think their CO2s are rising during the night, we can put them on non-invasive ventilation. And non-invasive ventilation, nocturnal non-invasive ventilation, has been shown to reduce exacerbations, reduce hospital stays, and also improve mortality. So we have other options. So unfortunately, when they do get deflated after I've told them valves might not be an option for you, I have some other alternatives that we can talk about. So I'm going to wrap it up there. I appreciate everybody listening, and we'll get to our questions here real quick. And for those of you, you probably have the answers to these now. What's the ideal forced expiratory volume range for a COPD patient to undergo interbronchial valve intervention? Well, it's that FEV1 of 15 to 45%. And it's not that, some patients do trend up a little bit more. They might have an FEV1 of 50, but they're extremely symptomatic. And I think all of you out there know now, it's not just about the PFT. We can have some folks that have PFTs that are god-awful, but yet that patient gets around just fine. And maybe that patient's not a candidate for valves. And then you've got patients, the PFTs don't look that bad, but they really struggle. So if their FEV1 might be a little higher than 45%, but they do have that air trapping and hyperinflation, that's a candidate I might still look at. So these aren't strict numbers, but it's just somewhere for all of us to know this is where we're going to get started, and this is what we're really looking for, but they might fall out of these numbers a little bit. And then lastly, what's the surgical procedure interbronchial valves are intended to replace? And everybody, I'm sure, got lung volume reduction surgery. So I'm going to leave it there, and if there's any questions, anybody on the panel, if you have questions for anybody on the panel, please feel free to ask. And thank you very much for listening. Thank you very much for attending.
Dr. Younger, thank you very much for your time today. Excellent presentation. We do have some questions that I'll go ahead and read these to you. Pull up my... So, do you treat homogeneous disease versus heterogeneous disease? So, tell the patients or the attendees about that.
So that's a great question. I mean, the studies are out there would suggest that those folks with heterogeneous disease are the ones that are going to benefit the most. And I really am looking for one lobe that is sicker than the rest of those 5 other lobes. Now, obviously, oftentimes I have more than one target, but I really want to see one lobe that's going to, if I take out one lobe and allow that healthier lobe to move into that space, if they're going to get some benefit. It's not to say I'm not going to treat a homogeneous patient. Somebody that has homogeneous disease, that's the patient I'm going to go ahead and get that SPECT CT. And that SPECT CT helps me determine, hey, is there one lobe that really isn't receiving too much blood flow, that if I take out that lobe that's not receiving blood flow, that's not helping the patient too much, if I take that out and free up that diaphragm a little bit and allow that other lobe that might still be just as sick to move into that space, maybe they gain some benefit as well. And so it's not that I won't treat, but we're typically looking for that person with heterogeneous disease. So good question.
Okay, Dr. Younger. Have you ever placed valves in patients with immunodeficiency?
That's a good question as well. I have not placed a valve in somebody with immunodeficiency, but it doesn't mean I wouldn't. I think if it's somebody with primary immunoglobulin deficiency, I think you can look at that. Somebody that might be on, maybe somebody with rheumatoid arthritis that doesn't have interstitial lung disease but has emphysema, and maybe they're on some of the biologics that do create some immunosuppression, I would still look at that if I thought that I was going to provide this patient some benefit. So it's weighing the risk and benefits, and I would have a good conversation with that patient, and they need to understand there is a small risk for pneumonia with this, and the risk with all comers was about 1%. So if this patient would develop pneumonia, that, you know, if pneumonia the first time, I'd probably treat with antibiotics. But if they go on to develop a recurrent pneumonia or a pneumonia in that same lobe that I've put valves in, then we may have to consider pulling those valves out if they're going to keep having a pneumonia. And that's similar to what we do with some of the patients that are on steroid inhalers. If they develop a pneumonia, we know they're all at risk for pneumonia, and there's about a 7% incidence on those steroid inhalers. But, you know, if you come back with a second pneumonia on a steroid inhaler, I'm going to really encourage you to, we probably need to get away from this and just put you on a dual bronchodilator and see how you do. So to answer your question, yes, I would still consider them, but we would have a good conversation about the risk-benefit.
Okay. So this one comes in from Randy Brock. Dr. Younger, have there been any issues with existing subclinical infections in the affected lung?
I myself have not seen that. I do believe there are some of those out there. Travis, I don't know if you can answer that better, knowing the all-comers out there, since I'm only familiar with our site.
I think you answered it well, Dr. Younger. I don't think we have a ton on that. Every patient is different, every center is different, but we don't have a lot of data on that.
Yeah, so I can tell you, patients do still develop their bronchitic episodes. Some of them still need antibiotics at times, but I haven't seen an increased preponderance after I've placed valves. So I'd say it's still in the similar range for infections, whether they had valves or not.
Okay, Dr. Younger, during this time of COVID, what are your thoughts on using web-based or virtual pulmonary rehab?
That's actually a great question, and I think that's come up with one of my patients. We do have some patients, especially in that first couple of months when all the rehab programs shut down. One of my patients did do some pulmonary rehab online. I think it's a great idea. I like the fact initially that patients are in that monitored environment. So many of them do have some apprehension about trying to do some of these exercises at home with no one else around. I think for the candidate, they've already started rehab, they've gone through a few weeks of classes. I think that's probably a good place for them to then move online, or especially after they've gone through that first 8 weeks, they can continue some of that rehab online if their insurance will continue to pay for it, or if they're willing to pay for it. But I think many of mine are apprehensive, at least initially, trying to do some exercise or push themselves without someone else there guiding them. So I'd say initially, I'm not sure my patients would go for it, but I think after they've got a few weeks under their belt, most of them would feel comfortable doing something like that. I think it's a great question.
Okay, so Dr. Younger, I know you mentioned that the PFTs are all pretty not completely set in stone, but if you had a patient that really wanted valves, would you treat hypothetically a patient with like a PaCO2 over 50, maybe like 51, 52, 53, or how would you kind of answer that?
So again, yeah, the answer is yes, I would. It's again, I mean, it's not a strict cutoff, but it's being cautious about what you do, and that's probably another. I'd look to see, if they've got primarily one lobe that's involved, and I think my taking out that lobe is going to provide them a significant benefit. So what I mean is, their other lobe on that side is real healthy. Then you know what? I might actually provide some benefit there, and their diffusion capacity may improve. I suspect their FEV1 is going to improve, and they're going to see improvement in that hyperinflation and air trapping. So we may actually see some improvement in the CO2. But if I've got somebody with strictly homogeneous disease, I'm not sure I'm going to see too much improvement there. So I'd probably, in that case, usually by the time I get the blood gas, that's a little more invasive. So I've already got a good idea what their spec, or not their spec, but their StratX looks like. So I have a pretty good idea if I might be able to take out a lobe or not. So in that case, the blood gas is going to help me. If I see a CO2 of 60, no, I'm not going to do that. But if I've got a CO2 of 51, 52, and I think my taking out that one lobe is really going to provide benefit and might even help diffusion a little bit, then yes, I still would.
Okay, perfect. And one other question that I'll actually step in here and answer is the procedure covered by major insurance and Medicare? And that question is yes. So we do have Medicare coverage. We are also getting approvals through most of our Medicare supplemental plans. We are on several of the major policies of major insurance companies, Aetna and Humana and United Healthcare. We have an outstanding, just so you know, we have an outstanding case management team here at Pulmonx that can work with individual practices where we will actually prior authorize each of the patients that each practice sends through. Our team of case managers are really good at this, and so what we're seeing is a really high percentage of approvals of even commercial payers that we're not on policy with. A lot of times it'll be denied, but once we get to the third appeal, it goes to an external appeal board, and a lot of times it's overturned simply through medical necessity. So from an insurance perspective, we see a lot of positive news, and we're hoping that we're going to continue to see more payers jump on board. So that's not been an inhibitor of this procedure. So, but with that being said, I think Dr. Younger, I think that covers all of the questions up to this point. So I certainly want to thank you and thank all the attendees and participants for your time today. We know you all are extremely busy, and ultimately we hope that this program provided you a lot of value and a lot of confidence that you can go and discuss with your patients about Zephyr valve, the process, the patient workup, the results, and the follow-up. And if you have any questions ever, please feel free to reach out to your rep at Pulmonx. and we will do everything in our power to get an answer to you as soon as we possibly can.